I am part of a Robong project, which is, as mentioned by Dr. Siniza just now, it's I'm not quite sure why it's overlap, but never mind. It's reducing barriers, okay, in early cancer diagnosis in urban 40 group. So as you can see, there are a lot of logos down there. These are our collaborative partners, our stakeholders. And you can see there's a map there because that's what we are trying to do. So the contents, I'm going to cover all this, okay? So I just want to bring you back to this picture because every day, well, not everybody, but most of us have mentioned about why patient tak datang, tak comply with the follow-up and all that. But I think we have got to go back to how the patient actually feel when they found something abnormal in their body, or they have a diagnosis, and what actually stops them, from coming to see us. Because when we are at the clinic, we kata, miss follow-up, ni mesti whatever lah, because we have a lot of complaints. But this is probably what the patient is feeling lost, don't know what to do, and especially when our project is on a B40 group, whatever that they have in the pocket is actually for survival. It's not for something for screening, because that's maybe a luxury to them to go for screening because they're well. So why should I go to see, do my breast mammogram or do whatever test that we need to do for them to do for screening. So the other thing is that if you look at the cancer pathways, they are actually very, very complicated. Okay, from pre-diagnosis to diagnosis to cancer management, surgery, chemotherapy and whatnot, and post-surgery care, chemotherapy and all that. And that's the patient care. We are not talking about the people around the patient, because as a primary care physician, we think about family as well, right? Okay, so these are all complicated. Overview, I think most of us have mentioned that is one of the highest causes of mortality, and we know for the fact that the cancer, about 60% of them presents at the latest stage. So what we're trying to do is to downstage of the patient at presentation. And the complexity of the pathway of cancer management is very, very crucial. That what we want to do in this project is to increase the cancer literacy and also to improve the navigation literacy through our complex health system. So the impact is not just for the patient, but we have got to remember the patient's family, the patient's physical and mental health, and to the patient, and of course to the economy of a country. So how do we close the gap? Because we want to make sure that the patient actually reach the destination, either to see the doctor at the clinic or to the hospital, the fastest and easiest way, because it is very complicated. And this is the cancer continuum, care continuum. So what I'm going to mention about is the community navigators, which is this project is all about, and also the importance here is that it is a pre-hospital thing that we want to do, implementation that we want to do. And this community navigator in this project is called Rakanku, which is Rakan Community Cancer Community. Okay. And so the project implementation is to create awareness, increase awareness, and to expedite care. So we have produced a training module. So we also need to know how to use the right cancer navigators or Rakanku and the training of Rakanku. So this is a picture of what we call kaca, because kaca always say cam cepat, cek cepat, ikut cakap pakar, and cegah kalau boleh. So we have, I think Prof. Rohima has mentioned about videos and all that. So please feel free to go into YouTube of our Cancer Robong project. So we have created a module called Robong Rakanku. We have 14 videos, which is YouTube, so accessible to anyone. And we have created so far Malay, which is our first phase of our project, and we have translated into Mandarin. The Tamil and English is on the way. We have translated the script, but we have not get the voice over yet. But I welcome Tamil speaking people who can read Tamil to join our voice over into our project, because that's my difficult at the moment. So we also have cancer navigation resource document, whereby how to navigate the patients to the hospital, klinik kesihatan, how to go, what day, because what day, what time that they can go to certain hospitals, because the cancers that we represent in our project is the 5 cancers, the breast cancer, cervical, lung, and also colorectal cancer. So they have to know if they need to go to the hospital, which day is the colorectal surgery clinic day and whatnot. Okay, so we also conduct a study tour whereby the community navigators, we teach them how to go to klinik kesihatan, how to get access to klinik kesihatan. Because when we did this study, we found out that the community navigators themselves do not know how to get access. They don't know how to use the MySejahtera or the Selangor app previously, how to make an appointment, okay? Let alone to guide others in the community to get access of the healthcare facilities. And we also have physical campaigns, which is done by another Rebung sub-program, but we all work together, okay? So the roles of community navigators are as such, because we have got to make sure that the community navigators know their roles, because we want to get the timely diagnosis and also to integrate. Because I feel that this community navigator is just like, parasite is not a nice word, but it's a person who can actually navigate through the healthcare system. Okay. So it will bridge the community to healthcare facilities, either to klinik kesihatan or the hospital. And I hope everybody knows that klinik kesihatan, every 10 kilometers, we have one klinik kesihatan. So it is that many, and we don't know why people are not going to see the doctors. Okay? But I think before we go here, why they don't see the doctor, that one of our researchers has actually done a study, and she found out that why they don't go to see the doctor, because they think, the patient think that it is because of buatan orang, black magic, okay? We're surprised, but that's what they think, okay? And it is a punishment, and it's a karma, so that actually stops them from going to see the doctor. And that's why some of them go to Bomo, complementary medicine, and all that. And I saw, when I was doing my master's, I saw one patient, so typical of what Dr. Siniza's patient, very young, 30s, with fungating breast cancer, and she actually waited about 2 to 3 years before coming back with very oozing and bleeding fungating breast cancer, because she went to complementary healers. So this is what we did. So we create the materials, we train the trainers 3 sessions. One of them are online. The first phase was done mainly online because of the COVID. COVID really controlled but it was a good problem at that time, because we actually used a lot of WhatsApp. We disseminated a lot of, into thousands of our project to the community. It was done in a Malay populated area at that time. And we had virtual and physical community campaigns. Now, during that time, we tried to see whether the community navigators can actually help the community to go to the screening and diagnostic centers. So we worked alongside the Klinik Kesihatan Taman Medan at that time, and the second phase we worked at a more Chinese populated area called Kampung Chempaka in PJ. And we also work with Hospital Shah Alam. So I was surprised myself, because I just found out that in Petaling area, Hospital Shah Alam is the only public hospital which serves the most populated and very densely populated area of Petaling. So you know how much that burden the hospital is carrying. So we try to work along with the private sectors as well with our project. So what we learned from phase 1 and 2 is that for Rebung 1.0, they're all female. We did have 2 male, but they just dispersed in the air. So we had to add on prostate cancer on the second phase 2. just so that the male we have more male Rakanku. And the Rakanku 1.0 engagement county leaders cohort, they use a lot of WhatsApp, high dissemination, but unfortunately poor engagement, because these are community leaders. They are non-medic, they don't have an experience in medicine, so they themselves need to be guided. So I think that's, it's more difficult how to engage them. And so in the second phase, we included the NGO in also using the Mandarin module. And excellent, NGOs, we tie them up together to work together in the project. So it was great because some of them are experienced. They are experienced. Some of them are survivors and they are doing it already, but maybe in silos. So we're trying to get everybody to work together. So we had some pre and post questionnaires, and that shows statistically significant improvement in cancer literacy and also navigation literacy, and also confidence in navigating the community among our participants for the Rakanku. Next. So this is the sustainability that we were trying to get is to collaborate, and I think NCSM has also agreed to be our call center. And we need long-term funding. So again, AstraZeneca, you're very welcome to fund, because as what Matron was saying, that the transportation was a huge problem for them to come to the hospital. And the next phase is going to be digitalization of the learning module, and also to how to navigate URI using the Slanka app. And we do need a strong relationship with the community services. I think Rose has mentioned about using the churches, temples, and masjid. So that's what we are doing at the moment as well. So that's it. Thank you very much.